This is with the Panhandle Health District. It's February 21st, 2023. The time is 1:31 p.m. In attendance are Commissioners Duncan and Matari. Commissioner Brooks has joined us by phone. Are there any changes to the agenda? Okay, hearing none, we'll go ahead and get our Panhandle Health District quarterly update with Director Don Duffy.
Great, thank you.
And then just push that little button there, and you're good.
I should have known that by now. Thank you, Commissioner. Appreciate that. And Commissioner Matari, nice to see you again.
Likewise, thank you.
Not in the airport, but great to have you here. And Commissioner Brooks, welcome as well.
Thank you.
This is just our quarterly update. I come once a quarter and kind of give you a Panhandle Health District update, but most important, this meeting is, we love to have this meeting for any questions or concerns that you're having with the health district. So I'll go ahead and get started, and if anything comes up, just please stop me and so that we can discuss. I would like to welcome with me today, I have Kim Young, who's our Division Administrator over Health Services. And also we have, I'll start on the other end, that's Kelsey Orlando. She's our Program Manager over Substance Use Disorder. And then one of her subordinates here is McKenna Hunsaker, who specifically has responsibility with our opioid settlement funding. And we're going to talk about that here in a moment. So right now at the Health District, a big part of what we're doing is our FY24 budget. And we're already in the throes of putting that together. You know, in FY23, our budget runs from July 1 through June 30. So we are working on the FY24 budget, which will begin July 1. And just a quick snapshot, so the FY23 budget, that was a $13 million budget with the little change in there. And of our budget, 81% comes from grants and fees. So grant would be something like our Women's, Infants, and Children grant, which is a grant from the Department of Agriculture. And we have many, many of those funding sources come from grants, really outside of the state. And then secondly are our fees, so clinical fees, septic tank fees, all of those comprise of it. So we come back to our counties asking for 19% of our budget to be funded by our counties. It's important to note that that's still a lot of money. Let's just call it what it is. For Kootenai County, that's around $1.685 million for FY23. However, I will say that of the 7 health districts around the state, we are by far the lowest in terms of what we ask our counties for. The average around the 7 health district is over 24% that they ask for their counties. If I were down in Boise, if you were a commissioner in Boise, for example, they would be asking for 30% of their budgets to be funded by the counties. If we asked for 30%, we'd be asking for an additional $1.5 million on top of what we ask for right now. So again, 19% is still a hunk of change. I get that. But we're happy where it is. It's been slowly dropping, 1% or 2% a year, and we hope to continue that. So again, we're actively working on that budget, and what we'll do for you as commissioners is we'll be coming back here probably close to the end of April, maybe 1st of May, and I'll bring our Chief Financial Officer with me, Christine Crummer, and we will present to you the FY24 budget at that time in details of what that will mean for Kootenai County. And there's no approval that's happened, but it's just to inform you of what that budget looks like. On May 25th, that's a key date because that's when the budget is actually brought up for approval. And that will happen at Panhandle Health District, and Commissioner Duncan, as the chairman, you are the one responsible to attend that. Basically, the Board of Health steps aside, the chair of each one of the county commissioners comes in of all 5 counties, and will vote on that budget. But again, we hope that you'll have a thorough understanding of that before you come to that meeting on May 25th. So more to come on that. Of course, budgets, there's a lot going on in our budget. You know, we're still battling with wages and what have you. You know, still 75% of our budget are salaries. Actually, 74% are salaries. Still the lowest in the state of all health districts. But we'll be looking at that and seeing what we may or may not be able to do for our employees as far as that goes. So we're looking at that closely. Another transition we're going through here with the health district is we're beginning, just the beginning stages of a new ERP system. That's an enterprise resource program. That's where all of our accounting, HR, all of that is how we process all of that information. We're transitioning to the new state system called Luma. We are hearing so far good reviews about that. And in a lot of ways, we're pretty excited about that because we know that it'll provide us much better reporting tools, particularly as we measure our performance standards. We'll be able to use that for better reporting. So, all those things are always a challenge, but we are doing our best to get prepared for that. And that will begin on July 1, that new system. So a lot of effort going into that right now. I think the third thing I wanted to mention, which I'll turn this over to our team here, is talking about the opioid settlement funds. What an interesting thing that is for us. And Commissioner, you and I talked about this quite a bit at the airport, and I really appreciated your thoughts about this, and I've thought about them since then. This is going to be somewhere in the neighborhood of around $700,000 to $800,000 for the next 12 to 16 years coming into the health districts. And we feel very responsible for that funds. And that includes the funding that Panhandle Health District has received, as well as counties. Some counties and cities have also allocated their funds to us. So that's a concern that we use that in a very efficient manner. Frankly, if we don't, I really don't want it. We have to use those funds efficiently to improve the health of our community. So what I've done is I have brought McKenna, and I'll let her go ahead and start. And she's going to talk to you about what our plan is moving forward. And really would like you to look at that seriously and give us your thoughts back. But before I do, I'll stop there. Do you have any questions before I transfer some time to McKenna?
Sure. And so she's going to handle the opioid section, right?
Yes.
So you had, the Panhandle Health District had some preparedness coordinator, or you have some, I guess that's all I would know how to call it, but like a little section in the house. So what's the status of that?
Well, we have our preparedness program here, and we get funding from the state to run that program. The funding that we get is for 2.5 FTEs.
Okay.
And we had more than that. We had 3.5 FTEs for that program. And I made the decision that we have to be more efficient with that, because what happens if we can't fund it? We're turning to you to help us fund that. And so we, with our division administrator, Eric Kettner, and I took a long, hard look at that program and decided that we could still have the good programs that we provide, but do that more efficiently than what we were doing. So we're simply paring down to be grant compliant. We have funding for 2.5 FTEs. That's what happened to that program. And our medical reserve corps program that we had with there, that's going to fall. We're currently hiring a new nurse manager. It's just replacing a position that left. And that position will be both our nurse manager and our MRC coordinator. So we'll have an RN actually running that program, which I think is also an efficient use of resources. So, but there's a lot happening, Commissioner, around the state regarding preparedness. A lot of discussion of where that's going. FY24 will be the same funding, but we've been meeting with folks from the state about what that's going to look like in FY25. And it looks like they're going to give a little more flexibility to individual health districts on how they use those funds, which I think is a good idea. And when we get that closer to a good discussion point, then we're going to reach out with the Office of Emergency Management. I think we need to learn to work better and be more efficient as an organization, as we found through the pandemic. And so we are not going to submit how we would use those funds in FY25 until we have a chance to visit with OEM here locally.
Okay. And did you have, you mentioned, the pandemic is probably one of the best uses of the preparedness coordinator department. Did you have like after action reports or anything like that?
Yeah, we do. We just, it's coming, let's see, it'll be on the 28th of February at our executive team meeting where the final product of the after action will be presented to us.
Okay. It's always interesting to me to look at those things and see what we learned and what we could do better next time.
Yeah,
so
it's actually mission critical. And we just didn't do our after action report just within our organization, but we surveyed our partners to get their perception on how we did. And so we'll look forward to seeing those results here in a couple of weeks.
Okay, great. All right, any questions?
I was just curious a little bit. You mentioned grants and then revenue from the counties. And I take it you have other sources of revenue as well for your budget.
Well, there's three sources.
Yeah.
There's our grant funding,
Mm-hmm.
there's our fees, and then there's county funding.
And are the fees, they're based on cost figures largely?
Well, there's a couple of different fees, right? One is our medical fees. We collect a fair amount of money for people coming into our clinics for medical care. And that is based on, it's based on what we call a conversion factor. I don't want to get too much into the details here, but for example, Medicare, they have a conversion factor of $36. And then you multiply the conversion factor by what's called a relative value unit. And a unit consists of cost, malpractice potential, a number of things. That relative value scale was produced years ago. So let's say you came in just for a doctor's visit. It might have an RVU of 1 times 36. So $36 is the allowable. You might come in for a complicated surgery. So that would be a 10 times 36, so $360. So we use that relative value scale, and then the only way we change fees is with our conversion factor. So Medicare is around $36, the Blues are like $70, and I believe ours is around $65 right now. So we don't just throw a dartboard and decide our medical fees. So it's kind of complicated, but that's how we determine it so that we're less than most here in the area in terms of our fees. And also I will say nobody gets turned away. Everyone's accepted regardless of their ability to pay. Then there's our fees like for our septic tanks, for example. And that fee for a standard septic evaluation is $1,050 right now. Now, to keep that in perspective, in Washington, just across the border, that's $1,600, and the homeowner also must have an engineer come out and actually engineer that. Who knows how much that is? For us, the whole thing, $1,050.
Okay.
How does that compare to other areas? Do you know, other health districts?
Well, I don't know to really ascertain that. I can find that out for you, Commissioner.
Okay.
But like I said, for our neighbors just in Spokane, it's much, much cheaper here.
Sure.
But I will find that out for you.
Okay. And I mean, just under Idaho law, we can only, as government entities, can only charge what it costs us to provide that service. So has that analysis ever been done at Panhandle?
Yes, we just did it. We just did it last year, actually, to make sure that this is not a revenue source for us. Yes, it's just to cover our fees. In contrast, another fee we have, Commissioner Matari, are when we go into restaurants and we do inspections. You know, last year in FY23, we lost about $160,000 in that program. So that fee is not yet up to covering our cost. But unlike septic fees, that fee is in statute. It's in Idaho state statute. So we don't have the latitude to change that fee. And there's been a lot of discussion around the state with health districts to raise that fee. But you can imagine the food side, lobby, they're like, understandably, don't want to see that going up. So,
Does
but
that have a bill number? Is that being
I
brought
will
forward?
find that out for you as well.
Okay.
Thank you. And so I'll let you know where that statute is located. But again, it's a concern because whatever we can't fund, the only source we can go back to are our counties. And it seems to us that those that are using that service should pay for that service. So we'll get you some more information on that.
Okay.
Okay. Thank you.
Great. Bill, any questions?
No, I have no questions. Every time Don comes to give us a report, he's very thorough. So, no questions.
Okay.
Thank you, Commissioner.
All right. I guess we're ready for you.
Great. Well, I will start us off. I'm Kelsey Orlando, so I'm the program manager over our substance use disorder team. So thank you, commissioners, for your time today. And our department oversees all of our funding that has to deal with substances, excluding tobacco and nicotine. So that's a number of illicit substances, as well as the history of our programming really began in the prescription pain pill crisis around 5 or 6 years ago. And today we now have these opioid settlement funds, which is a direct correlation to that crisis. And so as Dawn mentioned, there's a lot of money that's coming towards the state and being allocated throughout the health departments, the cities, the counties. And we've taken immense responsibility in making sure we're continuing our successful efforts and also taking the time to see where there might be gaps and needs and filling those in with this funding. So we work on a 4-pillar structure. So that includes our prevention, harm reduction, treatment, and recovery work. So our prevention work really looks at the education side, our families, youth, and making sure that there's education, awareness, and also programming that can help mitigate the start of use or really bleeding into our harm reduction work, where if someone is already using or in that accidental overdose situation, we're making sure that harms are reduced. So some of those programs include our Be the One programming, which is a new prevention initiative that packages our really effective evidence-based curriculums into a school intervention. It includes parents, teachers, school administration, and also has opportunities for youth to have direct education and involvement in this work. In regards to our harm reduction efforts, a lot of that comes down to our Narcan or naloxone access and availability and education. Some of that is in public spaces, so we have a number of nalox boxes, which are wall mounted. They're usually next to an AED for emergency circumstances. We have 48 of those in Kootenai County, everywhere from churches, schools, banks, and our Panhandle Health District offices, making sure Narcan is ready and available with the education on how to use it and how to call for emergency services. And then we also make sure that medications are disposed and locked appropriately. So we have a dispose, lock, carry program where medication lock boxes and disposal pouches are accessible in our clinics and also in our pharmacies, so that families can make sure that meds are safely stored, up and away, and then also if they're expired or unused, that they're going to the proper places. I'm going to turn time over to McKenna. She's going to lead kind of into our treatment and recovery sectors. And then also one thing that we're really proud of and excited to see is an application process we've created. And that is going to allow for community partners to apply for settlement funds. It's an easy application on our website that McKenna has worked hard on making available and accessible. And then as a team of 4 of us, we are reviewing those on a quarterly basis, making sure that the settlement funding is getting back into the hands of our community partners that know what they need, and then we can help as the fiduciary over it. So off to McKenna, unless there's questions you have for me up front.
No questions.
Bill, questions so far?
No questions.
Okay, thank you.
Perfect. I will go into our more treatment recovery side. So we do have an Idaho law enforcement diversion program. So that's pre-arrest diversion. So if they come in contact during a traffic stop and they meet qualifications, they can be diverted from charges to go through treatment. While we were discussing this avenue, the question kept coming up of why are we not doing this while they're in jail or incarcerated? Why are we diverting them? So that kind of led us to alternative options to what else we could do besides pre-arrest diversion to accompany that. And we kind of settled on this idea of offering opioid use treatment disorder while they're incarcerated and spending that less than your time in jail while they're a captive audience to help get them treatment. We looked at intensive outpatient treatment, which is about 9 hours a week, which our treatment provider and case manager had kind of suggested. I know that you guys have also kept your funding, and there was mention that you guys had the same thoughts about doing this in jail as well. So in good communication, we just wanted to kind of see today where you guys were at and what we can do as the health district to support you in that role from the information that we've already gathered, or if there's any further collaboration that we can have.
Okay. We have representatives from our jail. We have undersheriff and our captain over jail services. Did you guys want to chime in here now at all, or just? Okay, sounds good. Okay, yeah, we're kind of on that path, looking at how our funds can be applied to the jail, about cover money we're already spending for that use. But yeah, it's definitely a conversation that we're willing to have and partner with. So, okay. Is that it? Or
Unless you have questions or.
well, I guess my question would be: is that the only idea? Is to have 9 hours a week treatment for our people? I mean, is that like a counseling thing, or how's it?
That would be the starting point. I am not the treatment provider. She was unable to make it, so I'm kind of pinch hitting some answers. But the idea would be to start with 9 hours a week in that intensive outpatient, and that would be a licensed mental health professional that's qualified to preserve or provide those services.
And they would just come to the jail and meet with as many inmates as needed to do that.
Mm-hmm. And if more counseling or more services or medication was needed, then we could look into bringing in those services as well.
Okay.
To support that as well.
Yeah, Tegan, our psychosocial rehabilitation specialist, she's also our case manager for the law enforcement diversion program. She has talked to the defender's office about what that would look like during the criminal processing. So she's talked to their clinical social worker, Elise. She has also looked into what a mental health professional would look like in this setting and what the cost would be for us to kind of provide those services in a contract setting. That's what we've kind of come up with so far, and then kind of took a pause just depending, all the funding settling out.
Okay, great.
Tegan currently does a number of roles as well as patient navigation, and so helping people with the social determinants of health, so questions about maybe where housing has put them in the last week, or do they know where they're going to get their next meal from, and so using those screening tools to really make sure that people who meet our clinical providers are also being met with the necessary social services to be successful in their care, and that's really translated well into the ILED program, or the law enforcement diversion program. So she's built a lot of relationships within our community and has been able to get over 150 people services just through our clinical offices, and a number, roughly 60% of those, are a combination of substance use disorder and mental health counseling and treatment. So she's very knowledgeable and a great community partner with Idaho State Police in our diversion program. So that's a big benefit we've seen with her joining our team.
And are you looking to go into the 5 northern county jails?
Our hope is to start here in Kootenai County and then expand out. We have been working with Shoshone County for their diversion program, which also brought up this conversation as well.
Okay, great. All right, Bill, any questions?
No questions.
Okay, Bruce?
No questions.
All right, so I suppose we can close the meeting in just a minute here, and then you can go meet the folks who you directly work with over at the jail. So I will call, is that it, Director? Okay.
Thank you.
Great, then I will call for public comment. Nobody online, nobody on the phone, nobody in person. All right, 1:56, meeting adjourned. Thank you all.